Hello, my name is Ravi Vij. I'm Mike Cancer Haven, and today within our Conversations with Cancer Experts series, we have Dr. Peter Forsberg from the Colorado Blood Cancer Institute. He's someone that has a unique perspective. He used to be in academics and recently transferred to a large community practice that does still pioneering work in research. And so he hopefully can give us an inside scoop on how he's bringing bispecifics into a more of a community setup. So from the ivory tower to Main Street. So welcome, Peter.
Yeah, thanks, Robbie. Appreciate you having me, and happy to talk about it. I think this is one of the more kind of really exciting and important topics for us in the current myeloma landscape. Is how do we take these great treatments and how do we get them to more patients by getting them into community-based settings?
Yeah, I think that, these have been around for nearly, 2 years. And I think that the uptake in the community has been much slower than anticipated. And these are, as you said, really great drugs. And we need to have more patients be able to avail of these. So just to set the stage, I think, could you tell us about what are the bispecific antibodies that are approved in multiple myeloma?
Yeah, so in myeloma, we now have four approved bispecific T-cell engagers, three that have a similar kind of, approach, basically three that target BCMA, that would be teclistamab, elranatamab, and linvoseltamab. So those are our BCMA targeting bispecifics. We have one talquetamab that targets GPRC5D. And essentially what these do is, bind to the myeloma with a specific, antigen that they're targeting, and then they bind to CD3 on T cells, bring them close together, activate the T cells to kill myeloma cells, all four of the bispecifics were initially approved in a very similar setting, late relapse myeloma. Only over the past few weeks, we actually have our broader approval of teclistamab, which, is our first bispecific to now move into the early relapse setting, approval of the Majestic 3 trial, which was teclistamab plus daratumumab in patients with one prior line of therapy, is really going to dramatically expand the number of patients who are appropriate for this. And hopefully it'll be something that helps to, encourage that sort of progress that we know has been unfortunately kind of slow in the late relapse setting in terms of moving from, approvals of these really effective tools into accessibility.
So obviously, you said there are three approved, and initially for later line therapy. One of the things the community docs are going to want to know, there are three approved for the same indication for, at least initially for the same lines of therapy. Is there much in the way of efficacy difference between these?
I have a hard time finding too much in terms of discrete efficacy difference. Obviously it's the same as with most things when we're trying to compare across trials, how much do weight do you give to sort of differences that may be, less robust, I mean, all of them have an overall response rate in the late line setting. These three different trials, the phase two, pivotal studies that led to accelerated approval of teclistamab, elranatamab, and linvoseltamab were all done in relatively similar late line patients. There are some differences if you really look closely at high risk characteristics between them, but essentially they were all in patients with, a median of 5 prior lines, heavily pretreated patients, and they all had overall response rates between 60 and 70%. And when patients responded to each of them, they had pretty good durability. It gets a little tricky because in terms of medians, a lot of times the long-term response rate settled right around 50%. So you may have had patients who were a little bit above or a little bit below. But if you look, kind of across these, you see three really effective molecules, and ones where differentiating efficacy based on the late line data is tough for me.
What about tolerability?
Again, I think there's more similarities to my mind than differences. We'll talk a little bit about differences in dosing startup structure. Some of these are administered subcutaneously, others intravenously. That may lead to some differences in pharmacokinetics and sometimes the timeline to CRS events. There was, but they all have CRS rates that range between, 50 and 70% across these studies. CRS is a common side effect for most of these bispecifics. Alternatively, while it's a complication that gives a lot of concern in the community setting, neurologic toxicity or ICANS is quite rare. I think that they're very different profiles. Often the bispecifics kind of get lumped together with other T cell redirecting therapies like CAR T. And what we have learned is that the side effect profile is very differentiated from like CAR Ts and in a way that's much more manageable in a community-based setting. But it is something where across all of our approved CAR Ts, there is quite a bit of similar, CRS, almost all grade 1, occasional grade 2, almost all occurs exclusively during step up and first full dosing. And then it really smooths out. And I would say, sort of say from a quality of life and tolerance perspective, I think all three of the BCMA bispecifics have some of the most manageable and really positive quality of life associated with them of all of our myeloma treatments. There aren't many things that patients feel better 6 or 12 months into than they do with our BCMA bispecifics. Our GPRC5D bispecific a little more complicated. Talquetamab has a unique side effect profile with what we call the on target off tumor toxicities. That's our oral and cutaneous and nail toxicities. Those are more complicated, but in terms of the BCMA, more similar than different, although there are some characteristics of drug administration that may have an impact.
So obviously, the community doctors often will ask which one is the easier one to bring on board.
And I think that's it has they all have their own complexities. I think they, each all four of our approved bispecifics require step-up dosing. Each have two step-up dosing steps before their first full dose. They have been evaluated and sometimes have packages that reflect differences in initial trial design. Almost all of these were developed in trials that initially required hospitalization for CRS monitoring and management. With teclistamab and talquetamab, there was a recommendation in the package for 48 hours of monitoring after initial dosing. With elranatamab, it's a little less cumbersome, 48 hours after the first dose, 24 after the second, none after the first full dose. And with linvoseltamab, it's actually on a weekly dosing schedule, days 1, 8, and then, with 24 hours of monitoring after each. So some differences in recommended hospital observation, and then, some differences in long-term dosing structure as most of us in the areas where we diverge from what's the approved is how we dose these over time. We don't stick very closely to the approved weekly and then every other week dosing structure. Most of us are spacing these bispecifics out to much longer eventual intervals, which is something where, frequent practice is a little different. That can be confusing for community docs as well.
So let's dive into the meat of the issue. Obviously, you, a former academic and expert in myeloma, are now having to give these in the community setting. So, what is it that is going to be required for a successful initiation in a community practice?
Yeah, and I think, one of my, perspectives on this, comes from, I work at a, community center, but, I'm also part of this broad, what's called Sarah Cannon network, where I get a chance to meet with, colleagues and collaborators who are from very diverse community, oncology settings. And, I think most of us who also, share patients with large referring bases have gotten a broad sense for, how diverse the clinical practices that our colleagues are working in, as they try to think about how to bring these treatments into community settings, because, the infrastructure that most centers have is pretty divergent. What a multidisciplinary care team means, in different centers is going to be different. So every place is going to need its own, I think, approach. Unfortunately, that's one of the tricky things, is that I don't think there's going to be one size fits all. But I do think, in terms of being intentional and developing an approach to this, we are making progress in terms of identifying those things that you do need in terms of structured protocols, logistics, sort of tools to help community centers take on, to help sort of define what that program could look like for them and to meet programs, where they are in terms of what those resource differences are.
So let's take these one by one. What about infrastructure protocols and logistics? What are the pearls you can give the average community doc?
Yeah, so I think the most important thing is to sort of, some of this is, required as part of, sort of the startup, when you take on sort of the beginning of adopting this, I guess the first would be that, everything is achievable. I think for most of this, you need somebody who has the the motivation to make it happen. I think oftentimes that's the biggest rate limiting fact is, everybody's busy, everybody has a million things. So, how do we help folks who are stretched in a million different directions have a little bit of intentionality to sort of begin to flesh out this program? You do need some protocols for how you're going to monitor and manage toxicities, including CRS and neurotoxicities. You're going to need to sort of develop, and there are some resources for where you can find online, accessibility of SOPs and other tools that have been developed that can be then integrated into different community settings. You are going to want to start with some education across your program about what the anticipated side effects are and what the strategies are going to be. And then how you're going to monitor and measure those things. So who's going to be part of the process for identifying CRS events, for guide, for ensuring appropriate management. And then one of the bigger questions that many centers have to take on is, how is hospitalization going to fit into this? Is hospitalization going to be a core part of what we do? Are we going to be able to sort of manage this in a more outpatient-based setting? Because this is one of those areas where community practice are going to be very different. We are very enmeshed within a community hospital. We are a cell therapy and transplant center. So our approach to what we can do with our affiliated hospital is a little different. Whereas many community centers are going to have different access to a hospital or to either that they're associated with or that they're regionally affiliated with or that they're embedded within. So I think those are kind of the complex things that centers need to identify as they're getting the ball rolling on what the infrastructure might look like.
What are the key components of a team?
And I think this is another where there's going to be differences. I think, the way I see this slide is that the darker the color, the more consistently that's going to be part of your team. So, I think, almost, every team's going to involve a physician who's helping to guide the process. Most are going to have APPs and pharmacists. All are going to have nurses at some level. And then, exactly how integrated into your team a social worker or, ER staffing administrators might be kind of is going to depend a little bit, depending on what your setting is. So if you develop a program that involves dosing in a clinic and then hospitalizing a patient in an associated hospital for CRS monitoring. That's going to involve, hospitalists or, sort of a care team that might be managing a patient in the hospital setting. If you're going to try to pilot an all outpatient, it may mostly be your clinic staff with pharmacists and APPs most integrated. So I think there's going to be some diversity in terms of what a team might be, but it is going to cut across these different domains for where patients are cared for through the bispecific process.
So how do you do it at your own institution?
So we do, essentially all outpatient bispecific dosing. We do dose escalation in our clinic. We send patients home with a blood pressure cuff and a thermometer, and we have a caretaker who's looking after them for, the days after their step-up dosing and their first full dosing. And basically we have the patients, checking in the infusion center, coming in for a nursing visit on their days between doses. So basically we sort of structure it so that we would give, let's say, teclistamab on days 1, 4, and 8. In between that, the patients will come in for a nursing check on days 2, 3, 5, 6, 8, 9. That is specific to having outpatient, sort of capabilities on the weekend. So centers that don't have that would need to have a phone call check-in on a Saturday or Sunday as opposed to a nursing check-in. So there are some specifics that are going to be different practice to practice. But with that, we have very few patients who end up hospitalized for any amount of management through their process. If we need to give, we don't currently give prophylactic tocilizumab as part of our standard of care. We have a low threshold to give tocilizumab or dexamethasone for CRS management, on development of symptoms. And that's kind of our personal workflow. But this is one of those areas where there is going to be differences, and creating a one size fits all or even a one size fits most is a little bit more challenging.
And you mentioned you do all outpatient. So is there anybody you would admit to the hospital?
So a patient who needs to be admitted otherwise, a patient who doesn't have a caretaker to help look after them and support them through that 10-day process, and then certainly somebody who's, on the far end of frailty. But I think this is an area where every clinic's going to have to find their own approach, and where I do think that, selecting your initial patients kind of carefully is an important thing. If you're going to, begin to put your foot in the water of this stuff, trying to develop initiate with some patients who are on the more straightforward end of the spectrum, people who have low disease burden, who are younger and fitter, who have good support, is going to make it easier to get your first outpatient, your first community-based dosing done successfully. So it may be something where you sort of still, for the time being, a community center may want to refer to the academic center for startup dosing on patients who are, more frail, more complex, more comorbid. But then if you're going to try that process, for the first time, trying it with, somebody who's a little bit more straightforward is probably the easiest initial steps.
And what kind of patient and caregiver support and education do you think is important?
I think this is one of the most key parts of the whole process, especially if you're going to be doing outpatient-based dosing. If you're going to do dosing in the hospital, then or hospital-based, monitoring, then patient and caregiver education becomes much less impactful. If you're going to be doing this in an outpatient, setting, which some clinics are going to need to over time, just because they don't have, hospital capabilities, then having good information for patients and caregivers. That again, like I said, we give some vital sign monitoring tools. We give a log to write down those vitals. We give specific parameters for when to call, when to, potentially go to the emergency room. So I do think patients are going to need that, they're going to receive a wallet card. They're going to need specific sort of information. Much of this can be, acquired from the manufacturer for, to provide to patients. And then, patients do need to have some, clear understanding of what they're getting into and what the, anticipated toxicities might be. If a patient's going to be in the hospital, it's more straightforward. They're going to be monitored. They're going to have a team. That's where education of the team becomes more important, because then what you mostly need is for your, nocturnists and your pharmacists to know who and when is going to get, tocilizumab on the inpatient unit, as opposed to, whoever might answer the phone from the clinic side at 1 in the morning.
So obviously, the thing that sends the chills down the of average community doctor's spine is the word CRS. I think some of it comes from the time when we initially got CAR Ts and we had Yescarta and Tecartus, and we saw some of the horror stories percolate out. What is the average CRS like with these drugs?
Yeah, I mean, it's pretty different. With these drugs, the average CRS is just a fever, as opposed to the CRS that we see with, sort of our more intensive CAR T constructs, with bispecifics, often, sort of the large majority of CRS, may fit into a easier, label of a drug fever. It's often just a fever without associated vital sign changes. It can be, essentially if a patient receives an intervention with tocilizumab, it's likely the only dose of tocilizumab they'll ever need. Oftentimes patients can be managed. Some of our, guidance we've developed includes things like pocket dex, where a patient might have dexamethasone so that if they have a fever, they can call the clinic and be told, go ahead and take some dexamethasone, take your temperature again in an hour or two and see if you still have a fever. So I do think it's, while it carries the same label and has similar physiology, it is a horse of a different color than the CRS that we associate with our CAR T products.
And what about the neurological aspect of toxicity? I know there's ICANS in the case of CAR T, and we use the word ICANS in even bispecifics. I don't know if that is really even the appropriate word or whether it's just mild confusion due to the CRS.
That's my experience. I guess I shy away from calling it ICANS. I don't think I've ever seen true ICANS with a bispecific, and I kind of doubt that it really exists. With CAR Ts, we see ICANS as a very specific physiological phenomenon of inflammation that causes a specific type of neurologic change. What with bispecifics happens is occasionally a patient who's going through CRS gets confused, and almost always once the CRS is treated, their mental status clears as soon as the fever does as well. So I tend to think that of the things that are over promised but under delivered, neurologic toxicities with bispecifics is high on the list.
So, and for those who want to try to prevent CRS, I know you mentioned prophylactic TOCI in passing. So let's just get a little bit deeper into the weeds here. So what do we know about prophylactic tocilizumab? I understand even in prospective trials, it has been studied.
It has. There's been some, there's both been some, sort of structured prospective trials as well as some, sort of more broad, real world, sort of experience, that's been presented with prophylactic tocilizumab. And the answer is that prophylactic tocilizumab substantially reduces CRS. Giving a dose of tocilizumab, prior to your first step-up dosing of one of your bispecifics, especially the bispecifics that have tighter dosing structure. It's a little different when you have linvoseltamab and you're going to be doing weekly dosing. But tocilizumab has a relatively long half-life, and so usually giving that initial dose prior can help reduce CRS across your step-up and first full dosing structure. And so it does mitigate risk, and it now has been included in the NCCN as a potential supportive tool. Although I will say that the potential for reimbursement variability is still a concern for most centers as they're deciding whether this is a tool that they can apply.
And the other option, which has been studied at the Mayo Clinic, and we'll talk about some of your own research in this area in a minute, has looked at dexamethasone.
Yeah, there have been a couple groups that have looked at dexamethasone. The Mayo group includes it as part of their algorithm. That so basically we have a couple of different centers. Mayo. I think the next one is Emory. That really robust myeloma programs that have presented their experience with outpatient dosing. And they certainly show the feasibility of models. And every model that is presented and published is going to be a little different. Every place kind of develops a protocol that fits their institution. I think, and that's kind of the nature of these sort of data that have been presented. They certainly show proof of concept that you can do this. Emory leaned more on prophylactic tocilizumab. Mayo leaned more on kind of close monitoring, some, as needed for emergent symptom dexamethasone. MGH has presented some data about more structured dexamethasone dosing. So several different ways of kind of skinning that cat of trying to mitigate some of these side effects, make outpatient dosing as safe as possible. And essentially all of them have shown that outpatient dosing in their institution has gone well, has gone fine. That whatever these structured protocols are and institutional resources, that it's been able to be operationalized and integrated, without concern. And that kind of gets into what we've been doing, which is trying to take it a little bit of a step further. So, as you mentioned, part of my research is, across outpatient community-based settings, and that's where this OPTEC trial, which is an outpatient teclistamab study, which is a prospective phase 2, and we have mostly so far data on our what we call our arm A, which is a prophylactic tocilizumab intervention prior to first step-up dosing. So this was all done in an outpatient setting. Patients were required to be monitored. They needed to have nursing follow-up, kind of like what I mentioned we do for 2 days after their initial, sort of step-up dosing, their first full dosing. Over the weekend, many of the centers did not have weekend staffing, so that needed to be by phone. They were required to monitor their vitals twice a day. So take a temperature and a pulse oximeter twice a day. They needed to stay within 30 minutes of the treatment site on their startup and first full dosing windows. And they needed to have a companion, somebody to drive them and look after them, a caretaker, for 48 hours after each dose, including the 2 step-up doses and the first full dose. So that's our outpatient monitoring schema.
And this was done across the United States.
Yeah, so this was performed across many of our Sarah Cannon community-based network sites. So this is all the sites that are still participating. The OPTEC is an ongoing trial. I'll mention what we're doing next. And for many of the sites, this was the first time they've been at all involved with bispecific. So they went straight from, maybe we've taken on a patient or two from a university setting to do continuation dosing or no dose, no experience at all, to we're going to do our first doses outpatient in a community-based network with this structure. And so it was a big leap into the full program across these sites.
And so, what have we seen so far?
Well, it's gone well. So basically, this is our most recently presented data. This is from last year's SOHO. We're hoping to present updated data at ASCO this year. And, we're now actually getting closer to 50 patients who've, been treated. But in our first 25, we had 2 patients both with grade 1 CRS. That was all of our CRS. So, 8% total, which is lower than even the previously published outpatient or prophylactic tocilizumab data. We did not have any patients who were described to have ICANS. Basically there were no problems with patients, being sort of monitored in this outpatient setting, no events that escalated, no patients who got into hot water, so basically with prophylactic tocilizumab, it was quite a manageable intervention across these, relatively new to bispecific administration community sites.
Yeah, well, again, we do give prophylactic TOSI at our institution. And one thing I've seen since we instituted that, we don't even get that usual late night call with dexamethasone. I think a lot of people say it's overkill because it's an expensive drug and it adds to healthcare costs. But the fact is that you don't get that call. You don't have to, debate, should I send the patient to, an emergency room in the middle of the night or see him first thing in the morning. So I think that you're right, that there are, issues around the ability to deliver it in the community, though it is NCCN listed. There can be some issues that one will have to navigate, but that's one thing that is my own personal experience on it. But I think that the other thing, obviously, that you're looking at is obviously dexamethasone, which is much more economical. So tell us about
Yeah.
that.
So I think, you're right. I think if I were trying to create the most streamlined process to minimize complexities or side effects, I don't know that we're going to beat tocilizumab, but we do want to create diverse options, so
Sure.
that, if your community site is going to try to bring us in the mix and cost is substantial consideration, or the hassle of reimbursement and back and forth and prior authorizations, all those things, what's cheap and accessible is dexamethasone. And so basically, our next cohort that we're looking to sort of evaluate is a similar, sort of schema, but basically instead of prophylactic tocilizumab, we're going to build in more prophylactic dexamethasone. So this is going to be structured dosing basically during the windows when CRS is most likely to develop, which would be, so basically after your initial dosing, your two step-up doses in your first full dose, that night you get to take 8 milligrams of dexamethasone, the next morning and the following night. So patients will be, a little dexed out, so I think that's going to be sort of, I think that, maybe not anybody's favorite way to sort of feel. There's not going to be a lot of sleep. We're probably going to need to have some, sort of built-in benzodiazepine support along with this. But the hope would be that we sort of can see that there's a relatively substantial reduction in the CRS rate when we give a structured dexamethasone dosing schema like this.
So another obvious thing that once you're over the ramp up phase is the long-term issues that you have to deal with, and infections being the prime one. So what can you tell us about the use of IVIG to reduce infections?
Yeah. So while CRS is what keeps, this sort of slow, I think, has hindered the adoption in the community-based setting, that and packages that require hospitalization are recommended. What really has, initially kept most of us up at night about these bispecifics was the infection risk. And I do think maybe the biggest breakthrough we've had in terms of how we can make these tools the best version of themselves has been finding how impactful IVIG in particular support has been. This study out of Sinai was probably the first indication of that. I think we were all kind of taken aback by just how dramatic the reduction in the infections we worry most about. So this was basically data that showed that, through IVIG, you can have like a 90% reduction, this incidence rate of 0.1, 90% reduction in grade 3 through 5 infections. Those are the infections we worry about, the infections that lead to hospitalization or worse. And so, really sort of proof initially of how impactful this was compared to, we're so used to hypogam, we sort of dismiss it. But, this was the first indication that IVIG was a different thing with bispecifics than it might have been with our other myeloma treatments.
Seems it also impacts some long-term outcomes.
Yeah, and then this was, even more robust multi-institutional data, developing this sort of new system of infection-free or, infection-free survival and overall survival. I think that's been probably the most eye-opening is, how much device, and we moved into what we consider to be routine primary prophylaxis. Don't you, as soon as there's, emergent, hypogammaglobulinemia, some docs even advocate for before the development of hypogammaglobulinemia, starting your bispecific because, we know that this is going to prevent, infections which will be at risk to develop early on in dosing. So don't wait for a shoe to drop, so I think many of us have now started to label these, bispecific two drug combinations. Dara-Tech is not a two drug combination, it's a three drug combination. It's Dara-Tech and IVIG. That should be kind of part of our combo straight out of the conceptualization.
So what else can we do to reduce infections?
Yeah, and I think it's good that we've, got our acts together with this in terms of having, relatively consistent, consensus guidelines for this. So, essentially all patients who are going to start a bispecific, they're going to need, antiviral prophylaxis, acyclovir, valacyclovir for HSV or VZV/VZV. We're going to need to screen for Hep B. We're going to need to use PJP prophylaxis of some sort, whether that's Bactrim or Dapsone or, pentamidine, whatever your patient, sort of might need. We don't need routine antifungal or antibacterial prophylaxis outside of PJP prophylaxis. And I think most of us outside of that very specific window when CRS is a risk don't hesitate to use GCSF for emergent neutropenia. You don't want to be stacking multiple types of immunosuppression simultaneously, and we can often help support neutropenia more than we can some of the other things.
So I guess as far as vaccination goes, what is I think there's no consensus on this issue yet. So what is your own practice?
I would say that's one area where we're still probably, a work in progress with, sort of codifying our approach. Certainly this is a scenario where we think that seasonal vaccination is, that much more important. I think, like we do in some other settings, we tend to err on the side of maybe two flu shots, given a month apart. Certainly recommend, routine, if for patients who are amenable, COVID vaccinations. Obviously, that can be, complex in terms of some patients' preferences. And anybody with myeloma who hasn't had a pneumococcus vaccine should get one. Exactly when to give vaccines in a patient who's about to start a bispecific. It isn't. I think my perception of it has changed a bit as our dosing intervals have spaced out. It used to feel like you would never catch windows where you'd get very good immune responsiveness to vaccines. Now it might be something where if you have a patient who's doing startup dosing but will move towards monthly maintenance dosing, prioritizing vaccines when they're in that monthly maintenance window might make some sense. I'd sort of say it's probably an area where we need a little bit more, consensus and understanding of how best to approach. But certainly we're always going to be pro-vaccine folks in the myeloma clinic.
And just give us a flavor for what kind of infections are seen. When these were studied in the COVID era, people talked about CMV, they talked about aspergillus. Is that something you tackle, or is it the
I,
more routine upper respiratory tract infections, occasional pneumonias?
I'd sort of say in the era of less intensive dosing structures, and IVIG support, I do think that we've seen less of those complex, immunocompromised specific infections than we might have seen. I think all of us who were doing these trials in the early days, we saw patients who'd been through 6 or 7 lines of therapy. Their immune system was really compromised. We were giving such intensive dosing before we knew we needed IVIG support. We were seeing different things emerge. I would sort of say, and the data I think supports this in the earlier relapse studies that are the shape of my, sort of the bispecific utilization to come, that we're really not seeing those, complex, very immune compromised, patient population infections the way we did when these were first evaluated in 2021, 2022, 2023.
So one of the things you hinted at was less intense. So I guess we're not following the FDA packet insert sometimes.
I almost never do. Essentially, I think that, and that's the direction that the studies are moving. We now have a new dosing structure that's been approved with teclistamab, with the Majestic 3 data that I mentioned before. That's a dosing schedule that kind of mirrored daratumumab, going from weekly for the first 2 cycles to every other week and then eventually monthly. I think the importance of spacing out dosing with your BCMA-directed bispecifics is more urgent than with your GPRC5D. This infection risk we just talked about is a little bit specific to BCMA bispecifics. The infection risk with GPRC5D bispecifics is definitely different. You don't have as many B cells that are taken out by your bispecific. So I do feel that it's pretty, consistent in my mind that we should be spacing out our BCMA bispecific dosing to reduce infection risk. With GPRC5D bispecifics, our side effects are different. And often in that setting, we are spacing out dosing more to deal with the severity of dysgeusia, sort of prevent weight loss. I do think, and truthfully, I think a lot of us suspect that we may actually get as much or more bang for our buck with spaced out dosing. The more you let your T cells recover, between repeated stimulations with your bispecific, you may get a more robust, antibody associated effect. So certainly I think the proof of how well less frequent dosing works for itself, speaks from that Majestic 3 data. We've never seen anything that looks quite so good. So, certainly I don't think we are seeing a picture of less frequent dosing being detrimental to efficacy, and so, GPRC5D toxicities, I do tend to think of talquetamab as being something of a different animal in terms of, how we have to approach it. And, if a site were deciding which bispecific to start first, I would probably encourage starting with BCMA, getting comfortable with that just because it has a more straightforward long-term side effect profile before you kind of get in the mix with GPRC5D, because these are ones where, trying to help support patients, often they have a rough experience with these side effects, especially during the first month or two. In general, if you can get over the hump with those first few months, things do tend to settle down, and most patients get into a relatively manageable place over time. But the first few months can be a bit of a shock in terms of, all of a sudden 3 weeks in, everything tastes like cardboard. It's pretty impressively uniform that patients have that experience. But it is something that in the right circumstance can be a really impactful tool given how well they work.
But I guess, the fact is, this is not the future. This is the present. And I guess community doctors just have to ultimately get over their initial reluctance and I guess develop their protocols. And do you have any other parting words of wisdom?
No, I mean, I think that this is an area where we all have to have like kind of work together. I think this is sort of an interface between community docs and what their needs are. Obviously, our pharma partners have lots of enthusiasm and incentive to try to help bridge this gap. And I do think for most of us who spend time, doing research or at the interface between university, community, sort of resource limited settings, I do think that this, to my mind, is the most important thing we can kind of keep our focus on is how can we enable these clinics, give them better tools, give them better data to help people feel comfortable moving this into the clinic.
Yeah, as we said at the beginning, patients need it. These are revolutionary drugs, not evolutionary drugs. And I think if they can't get it, it is going to be, a sad thing for a lot of patients.
Yeah, yeah, no, these are life-saving. It's the impact, the effectiveness. Once you do it one or two times, and that's kind of what I tell my community docs is once you do it, you're going to see how manageable it is and how darn effective it is, and you're never going to want to stop giving them because they are really profound in their impact on myeloma patients' lives.
So I wish to once again thank you very much for taking the time to provide a unique perspective. As I said, both having the academic and the community background, it is invaluable. And I hope I can have you back to talk to us about more topics in this rapidly evolving arena.
Yeah, thank you much for having me.
Thank you.